Hi, everybody. This is a podcast where real doctors discuss fake medical emergencies. That means that unless your brother Ferris is faking a life-threatening illness to get out of school, this podcast is not medical advice. If you need medical advice or medical care, please contact your doctor.
Hi, everybody. I'm Jackson Bain.
I'm Johnny Kolosinski. You might remember me from such podcasts as Waiting for Bilbo, an absurdist audio drama set in Middle-earth.
Oh, that's terrible.
This is Hi Everybody, a bad medicine podcast. Every week we talk about what Hollywood gets right and wrong about medicine and how the body works. I was going to go with Boromir and Faramir are dead, but decided to go with the more popular absurdist play from the 70s.
That felt hard.
So you can find this podcast online at Hi Everybody MD on Facebook, Twitter, and Instagram, or at www.hieverybodymd.com or Jackson Bain.
You can call us at 530-DOCTORB. That is 530-DOCTORB. The B this week stands for bowel, which is actually a big plot point of the episode we're doing this week.
Yeah, this week we're talking about Chicago Med for the first time, based on some stuff I saw on Facebook a couple weeks ago. Going to be talking about season 5, episode 5, A Friend in Me, and we are joined for the first time by Dr. Scott Herskovitz.
Hey, how you doing?
Scott, you want to tell us a little bit about yourself?
Yeah, sure. So I'm a pediatric emergency doctor. I actually work with the, inimitable Jackson Bain at a hospital in San Diego. So I grew up in Southern California and have had ties to the community for quite a while. I enjoy a lot of movies and love to criticize them just as much as these guys. So I'm really happy to be here and able to criticize them and maybe give a couple bonus points for some good job that they do as well.
Yeah. This was, I think, all of our first Chicago Med episode, and it is drama.
Yeah. As a former Chicagoan, I would not say it's this dramatic in their ERs and whatnot, at least when I rotated through there. This was rough.
As a native Midwesterner, everyone was way too skinny. I can say that. They're my people.
Yeah. I was just transplanted over there. I can't say that and can't make that judgment. No, I will say the one weird accurate thing is all the attendings that wore white coats wore gray coats, which is actually a thing over there.
Really?
So their attendings don't wear white long coats. They wear long gray coats to differentiate themselves from the residents. Huh. So Oliver Babish, the psych, I don't know what his name was, he was dressed in a gray coat because he was an attending psychiatric physician.
Okay.
Whereas the resident, who was the ER resident, who was in the OR for some reason, doing surgery, was wearing a white coat.
What was that all about? He's an intern he's an intern ED resident, but he's going to surgery?
He was technically a third-year emergency resident because he was under Dr. Choi, the Asian doctor's tutelage for 2 years. And then now he's under the tutelage of the macho surgeon, Dr. Marcel. So I think this is a good jumping point to the first case, which is the bowel case, because it made no sense at all. But I can briefly describe it. It was just this guy named Carl had chronic abdominal pain, moved here from Tennessee to Chicago, and is saying that he has really bad belly pain.
Yeah, and he was, as far as people that we've seen that have real, real illnesses as opposed to Fast and the Furious kidney dialysis through an iPad. He was possibly the grayest and most sickly looking person we've seen that wasn't a zombie.
Yeah, he was real pale. Probably one of the more pale people I think they've made look on TV. But he looked so comfortable and had normal vital signs. And they kind of talked about all the labs and stuff they did. I don't know if you guys caught that part, but he rattled off a bunch of tests. I'm going to get a chest x-ray and a belly x-ray and CBC and all this other stuff. And they just go, oh, yeah, he's anemic. And that's it.
So they did all those lab tests. And I don't know if did he even examine the patient? I was watching and I was like, did you feel his abdomen?
No.
You know what I mean? when I see an abdominal pain patient, I don't go like,
Wait. You don't walk by
Yeah.
the room and go, surgical, not surgical, surgical.
I mean, if I was a surgeon, I would. That's why, of course, I would just be like, yep, nope, yeah. But, we're not surgeons. So the thing was crazy.
Yeah. And I would say the first thing I thought of, like, I was trying to play along and play guess the diagnosis. I'm like, cancer? Question mark? Before, like, they even said what he had with the chronic abdominal pain and whatnot, which is probably one of the most, I would say, frustrating diagnoses or chief complaints that we deal with in the emergency department.
Yeah.
Could Carl have just had too many hot Cheetos?
Takis, buddy. Takis.
Chicago's a hot Cheetos town.
Chicago's might be a hot Polish town.
I was gonna say it's probably Polish sausage and deep dish pizza.
He's from Nashville, man. He just hot chicken picks, baby.
So it's a hot chicken tummy.
Yeah, know it.
So he's got hot chicken tummy, and then like he's got like an obstruction or some sort of like that. And like I swear, those patients that have been doctor shopping or moving around, that's like the most frustrating thing I think to deal with as an ER doctor, because you can't dig up their records or anything like that.
That was the frustration that they had, was that the whatever hospital he went to in Tennessee was out of business, and so they were trying to get his records from Jim Bob's discount medical record shop, and couldn't find them.
Yeah. Have you heard of this before? Like hospital records being held hostage for money?
No. I don't know how that's legal.
Because that's what they said,
hostage.
Right? That's what they said. They said it was the hospital's bankrupt. They want to destroy these medical records unless they get paid or something like that. Like, I don't understand how that works in the real world.
Yeah, I don't get that. I'm pretty sure the technical owner of those patients' medical records is the patient. So I don't think you can just destroy them for no reason. But come on. I mean, I don't know. That whole part of the episode was just a non-starter. I was like, you just threw that in for it's not important. Like, we have enough chronic abdominal pain patients that come into the emergency department. You don't need to throw that in. Just be like, yeah, he's got abdominal pain for the past 20 years. We don't know why. Oh, perfect. You know what we're not going to find out today? What's wrong with him? That's exactly how it goes.
I mean, I think you and I would both agree on this, Scott, that usually we preface those chronic abdominal pains like, look, we might not figure out what's wrong, but at least we'll figure out what's not going to kill you.
Yeah, I mean, honestly, I think a lot of people struggle with these patients, but in my mind, they're super easy. They're there. Like, could something be going wrong? Sure. In this case, this guy is jacked up, but this is an easy patient. Like, the one time where you end up shotgunning lab tests and potentially imaging, it's probably the one time you're going to do it, because it's more to say, right? Like, as you said, you're going to be okay versus, hey, we're going to find an answer or you're going to die right now.
Yeah. And I'm surprised. I was going to say, the one test they didn't order was a lipase, which I always check for abdominal pain.
And what's that?
So lipase is an enzyme that's made in your pancreas, which is what was wrong in this patient, which was because, they tossed out a lot of big words. Like, we're going to do an angiogram and a CT contrast of your abdomen. But they took him in and he was really unstable. Like, he looked like crap. Like, that's a patient I'd be a little more tenuous about taking to the scanner, because if he codes, you can see there's not that much room to work in there.
They were really worried that he was going to vomit in the scanner.
That's like the least concerning thing. I think the thing that I would be most upset about if someone vomits in the scanner is that they moved.
Mm-hmm. So the scan's not valid.
Yeah.
That's the one thing. That's the one thing I'll give that Dr. Choi, right? He was like, man, he moved. It wasn't a good scan. And I'm like, dude, you're right, because that happens and it pisses us all off.
Because all you see is like fuzz where you need to look at. I'm like, I can't tell what this is. And you know what's going to help? An MRI with a very anxious patient. Like, impossible. You're going through a cave.
Yeah,
so that's a little tough.
A CT scan takes like less than a minute. An MRI can take, 10, 20, 30 minutes for them to actually do this. So you're like, all right, we're going to do an MRI for a guy who couldn't couldn't lay still for 30 seconds. Come on. Like, you think that's going to work? Come on, buddy. You were on the right path for a second there, but
you have to be right though. I've never seen a surgeon so anxious to take a patient to the OR. That's the other thing too.
Or an ED doc so militant about not letting a patient go to the surgical service or be admitted. I'd be like, oh, you want to take them? Oh, okay. All right, sounds good. As long as they're not dying right here, I'm all for it.
See, Johnny, this is what I was talking about I don't care where you go, as long as you're not in my department anymore. That's like the most important thing, unfortunately. Is like we're trying to free up those beds as quick as possible.
Right. Your goal in this situation would be to send him out still uncomfortable but living to poop another day, or take him say, well, this is something more serious than we're going to be able to treat in the few hours that you're in our dimly lit bed.
Yeah,
and
that's the darkest ER, I swear to God.
Yeah, but it was really it had some really nice lighting. I thought it was really intimate.
Yeah, the ambiance was great.
Also, richest hospital ever. All those like cows are Apple. They're all on iPads. Like they are fancy hospitals.
What is a cow?
Computer on wheels.
On wheels.
I'm sorry, we're supposed to call them WOWs, workstation on wheels, because the urban legend of hospitals is a mom got upset that we called it a cow.
Yeah.
Like someone moved that cow and thought that we're talking about a parent. So
yeah, that was cows. Now WOWs.
Now WOWs.
Yeah, that was a really nice ED. I was like, look, unless this is some like crazy private hospital in Chicago, I'll tell you what, Cook County don't look like that.
No.
It doesn't.
I can tell you right now, Cook County, Rush, Loyola, Mount Sinai, the ones that are all around that area do not look like that. As a guy who rotated in Chicago, I can tell you that very clearly.
That's crazy.
One of the things that you brought up was, okay, you've got this ER resident who is taking a gap year as a surgeon.
Sure.
But so when you do your rotations through all the different departments, that's something you're doing in med school, right? So it's not something you're doing.
You do it in residence. You do it in residency too. So emergency medicine will rotate through like the pediatric ER, the ICU, the trauma ICU, do toxicology. Basically kind of also rotate through various parts, and then also, but the majority of their residency is in the emergency department.
Okay.
Whether or not you scrub into a case, that's very unlikely.
And scrubbing into a case as an emergency medicine resident and the surgeon being like, tell me your approach, doctor. And you're like, well, I'm going to go a medial incision. I'm going to retract this. Like, whoa. Unless you got the textbook out in front of you about the surgical pathways to approach the pancreas and how to dissect that and remove it, man, that is the best emergency medicine resident of all time.
I would never be able to say any of that stuff, like how to approach or anything like that. Also, they touch his face a lot when he's scrubbed in. Which is always the problem with OR scenes, is they're always touching their face and adjusting stuff. But never have I ever seen a resident that's not a surgical resident scrub in and actually get to do the first cut.
Yeah.
It's like super rare.
Not even on his birthday?
Those are different times though. If it's your birthday, you get to wear a birthday hat and then you get to cut. That's how it works. But
I mean, you're right. I mean, that's the thing is not maybe a third year surgical resident would be being able to perform the surgery. Like a first or second year surgical resident, they're there as an assist. Mm-hmm. A third or fourth year, maybe a fourth year, yes. But a third year, shoot, man, a simple, straightforward appendix, they're still watched like a hawk. And that's still not exactly the most standalone procedure for them. It's not like the surgeon's like, tell me what to do. and you do it. They're going to be right there doing it with them.
Yeah.
We kind of saw this in the episode of The Resident we talked about last week, where the surgeon went for a drive and left his residents to perform the surgery. But that surgeon was also a cocky asshole.
Yes. I would never let any surgeon, especially a newbie, do any kind of surgery by themselves. I barely let my residents sew, like if they're first year, by themselves, like a laceration. I'm like watching them like a hawk. Because sometimes they go, I know what I'm doing. You come in and it looks like a murder.
Mm-hmm.
You're like, okay, I need to watch you carefully and prove that you know what you're doing before I let you do anything by yourself. Like super cautious about that stuff because it looks bad. And I think this is one of those situations where you have an off-service resident doing a bunch of random stuff, especially if it's bowel resection and cutting out the pancreas, which I learned in medical school is not your friend. The pancreas hates you and will act up and will be at any moment trying to kill you.
Hey, so they got that right. They got that right, Jackson.
They did. They did say the pancreas is not your friend or something along those lines. The pancreas is not your friend.
Cool. That was actually one of the things that I had a question about. So sweet.
Yeah.
So
pancreatic cancer, bad.
Right.
Pancreatic cyst, bad. You can't take it out because it's really hard to dig in there to get it out. And then if it goes away, you need to take enzymes for the rest of your life. Otherwise, you die.
Okay.
So it's bad.
So pancreas is more your frenemy.
It's more like your enemy.
Okay. Carl is also the only character in this episode whose name I remembered.
Okay.
So anything else to say about Carl?
Tummy pain guy?
Yeah, tummy pain guy?
No. We'll talk more about how to fix it later.
Okay.
I mean, the only thing, like that interaction between, I mean, I will say the arrogance that the surgeon portrays is not uncommon. And that is something that you hear more over the phone. It rarely are you having the attending surgeon down in the emergency department looking for patients, unless they're there for a particular reason. If they're there because they just did an appendicitis case and they're like, hey guys, is there anything else you got for me? I'm here. That's the only time the attending surgeon is gonna have that conversation with you. Otherwise,
and they're on the way home.
Yes. Otherwise, no. They're like, don't talk to me. I'm out of here. Whatever you're gonna tell me is wrong. So leave me alone.
Yeah. I mean, the only time I've ever talked to a surgeon where they're like, hey, is there anything brewing for me? It's like, look, I'm about to go home. I mean, I'm here if you need me, but is there anything brewing right now so I can get ready or just kind of prep?
But please need me in the next 45 minutes or not at all.
Correct.
Yeah, and I'm pretty sure there's only one surgeon that I know, at least at our hospital, who would actually do that. And he's a good guy.
Yeah, he's very good.
Let's move on to the mental health patient next.
I was going to say that one. Oh God,
Eunice the lawyer.
The immediate groan of both of us on that one.
Yeah, this is the scene with Oliver Babish from West Wing, and forget the character's name.
I don't know
the actor's name. He's either Oliver Sacks or Oliver Platt. One of them, he's Oliver Platt. The other one wrote My Husband the Hat and Sybil. And I always confused the two. And for a while, I actually thought that the guy who basically discovered dissociative identity disorder also moonlit as an actor on The West Wing.
Not in this case, but that would have worked a little bit if that's the case.
Question one before we get into this into this case.
They crammed way too many cases in this episode. Yes.
Yeah, 4.
5.
5?
5.
Oh yeah, because there was the doctor with cancer. Is he really just the same doctor from Flatliners?
Oh God.
It took place in Chicago.
God. Oh my God, you just blew my mind.
Yeah, he is exactly the same age as he would be had he aged up.
Yeah, but he was dead. No, he wasn't.
No, he lived.
He didn't flatline, right? Or did he?
No, if he did flatline, I don't know.
His was boring.
He lived.
Yeah,
because he was the voice of reason.
He might have been the Flatliners doc. Someone should tweet that to them.
Yeah.
Johnny.
But also, as a tangent, we really need to do 17 People from West Wing.
Okay. That's on my list.
So this was a situation where we had a lawyer come. It basically the equivalent of the actress from Scrubs who died, the character from Scrubs who died of rabies. Somebody comes in with way too much, who's hyperactive, high pressure lifestyle. Turns out she's bipolar, and wants to be admitted, or the doctor wants to admit her, and she's against it.
Yeah, so it's a 25-year-old female lawyer not sleeping for 2 days. I will say the first thing I would ask for if they were brought in by the police and someone was that manic was like, drug screen now, please, thank you. Because I mean, I don't know how Scott feels, but I'm thinking cocaine, 100%.
It was in my mind. I was like, dude, that girl's been like straight up.
That's the only way she can get through all that stuff. But I would also say putting a psych patient in that kind of room with all that stuff is not safe. I don't know if you noticed, there was so many things in that room. Like the monitor, the code cart was in the room. And then, which we learned later in the episode, all those rooms can lock from the inside.
Yeah, I didn't think about that with the psych patient, but you're absolutely right.
You don't want a psych patient or any patient being able to barricade themselves in a room. Like even our bathrooms, we can knock them down, like take off the hinges and get in. But all those rooms potentially can be locked from the inside. And that is not safe.
Yeah, I'm pretty sure from a logistical standpoint, when designing the emergency department, that's the last thing that you would choose. So, not real.
Yeah. So she comes in super manic.
Yeah.
And Dr. Howard?
Sure.
Question mark?
Sure.
Oliver Babish wants to admit her for psychiatric care because, well, she's obviously manic. Did they say what drug they gave her to calm down the episode?
Didn't hear it. There was like some kind of DMAT or whatever it was, and I didn't hear it clearly. But she was given that. She went to sleep, and then she feels much better. And then she talks about how she was $300,000 in debt, and she needs to work hard. I'm like, I feel you.
I know. I think about that all the time. I was like, wait, that makes you manic because you're flipping out because you got to pay $1 billion worth of debt. I'm pretty sure I think about that every day.
Yeah, you got to calm down, woman. It's okay. But you can't work that hard in a law firm. A law firm will not care that much. They care about results, and if your results are tainted by how much you're staying up and going nuts, it doesn't matter.
Right. Yeah. I've dealt with people having actual manic episodes, and yes, they can do a lot, and they can they have a lot of output of creative and out of the box ideas, but none of them are actually effective ideas.
No.
Yeah.
And then she goes let's not.
No, go for it.
No, I was going to say so Dr. Babish just goes, hey, I think you need some help. And the patient just goes, I want to go home. I want to go to the firm. She goes, I know what an involuntary hospital is, or hospitalization is. I don't want to do it. I don't think she gets the point, but the doctor goes along with it.
Yeah, I mean, I'm with you there as well. So as a lawyer, but maybe this is a lawyer thing, just because you're a lawyer doesn't mean you know everything about every single aspect of law. But maybe you think you do. I don't know. Just, I'm a doctor, but I don't know everything about surgery. At the same time, she probably does have an understanding of what her rights are in regards to an involuntary medical hold. At the same time, just because you say, I know what my rights are, doesn't mean that the doctor in that situation can't go, oh, really? That's fascinating. However, you're a danger to yourself and a danger to others. We're going to keep you in the hospital. That's all. That's all that has to be done. And I think that's the thing that people miss or don't understand is, one, we don't want to have to do that. I mean, maybe that's the impetus behind the conversation that's had. Maybe that's why he goes along with it. And I get that, because I don't want to force somebody to stay in the hospital if I don't have to. I'd rather it to be a mutual decision, especially with an adult. But at the same time, you don't actually have the right to say, just because you know your rights, that means that you can't stay in the hospital, that you don't have to stay in the hospital.
And even if you do, it's great. You absolutely have the right to,
not participate.
Not participate. Well, A, not participate, but B, hey, you can absolutely protest. It's Friday at 7:50 p.m., so you can log your complaint first thing Monday morning, and see when the judge will see when the judge will listen. So Scott, this is my second time really talking to Scott. So sorry to get really personal here for a second, but I actually was 5150 once for depression, and I did kind of have a similar conversation. But I also knew that if I didn't go along with it, I'd probably still be getting put away for a minute. So.
Yeah, I mean, I'm with you. I think Jax and I are both insanely sympathetic to these cases.
Oh yeah, definitely.
The emergency department is a horrible place for psychiatric care. It just so happens to be that's the way that our medical system is set up, and it's not just the United States. So people who criticize the United States for our crappy psychiatric care, guess what? It's not just
everywhere.
Us. It's a lot of places. However, you're right. Like when you make that statement of I didn't want to necessarily go along with it. I don't know if I necessarily needed it, but I understood the ramifications of it, or not the ramifications, but the logical consequences of this. Like I can say no, but like you said, it's a Friday. You know what? A judge is not going to override that 5150 at 7:00 on a Friday night.
Right.
And I think most doctors would avoid having that type of confrontation. I think most of us don't want that. I think we'd rather, if that means that I have to spend an hour talking to you face to face and that takes my time away from somebody else, that's fine. If I really think that is the best thing for you, that's what it is. And I hope that you see that. But I think sometimes in these when we talk about psychiatric care and when it's portrayed in television, it's portrayed horribly.
It is, yeah,
horribly.
And just as a side note, because Scott, we haven't ever talked about this before, and B, anyone who's listening, it was absolutely the right thing to happen for me. And if you're in a situation like that, absolutely seek help.
Yeah.
And it was one of the best things that ever happened to me. So just want to put that out there too.
And the doctors aren't trying to be the bad guys in the situation, putting someone on a hold or a 5150 or anything like that. A lot of times it's because you might not have the insight to see what's going on, like staying up for 2 days, not sleeping, going manic, scaring people around you, having someone actually call the police to pick you up. You might not be in that right mind frame to make those decisions. And that's why a doctor would put you on a hold, not just to or not to be mean, but it's really to protect yourself.
Right.
And to protect the patient from themselves.
Right.
Like when we sign a 5150, at least in the state of California, there has to be a justification. So it's gravely disabled, which I think is the case for this patient, or danger to self or danger to others. And this is a patient that is so manic that she's not going to be able to take care of herself.
And it's kind of like the same situation with Carl, where if you've got somebody coming in with abdominal pain, your goal is to send them home because they'll be a little less comfortable than normal, but fine.
Sending them home safely.
Right.
That's the key with anything in emergency medicine is if you're sending someone home, you send them home safely. and always giving them lots of instructions of when to come back. And I think in this case, clearly this is a patient that should not go home because he was pale as well, you know.
No, you're right. You're 100% right.
Oh, and I would never send a patient like this home. And I would be calling a surgeon. And here's the other thing. If the kid did have an obstruction, he'd have an NG tube by now. I'm just saying.
Don't go back to Carl. Let Carl die.
They saved him. He's fine. He went over there. Also, the surgeon whispering over while he was under anesthesia, it's going to be an easy surgery. Who the hell does that? This is not an easy surgery.
They were just trying to make it sound like he has a heart, okay? That he's not like the surgeon that's like, you, not surgical. You, not surgical. I think your mom's hot. That's, it's, come on.
I think I wrote in the beginning, before we discussed all of this, I said, this show is effing dramatic. Why is it so effing dramatic? Why is it more dramatic than The Resident? I can't handle this.
Yeah, I got a barrage of text messages over like 5.5 minutes from Jackson.
I could not handle it.
Well, yeah, I don't know. The psych stuff bothers me still. Like, it really bothers me.
Yeah, but I don't like. And how did he diagnose her with bipolar with mania so quickly?
All right, time compression. I'm giving it the time compression.
Fair. They need to not do
go.
5 cases. So what? This is an episode that runs 48 minutes, which seems 48 on 5 hours, and they ran like 5 episodes or 5 different medical cases in it. That's too many.
Yeah. Question about her situation before we move on to patient 3 of 5. Eventually, she goes to the hospital chapel. And and that's where she has the heart-to-heart with Oliver Babish of, maybe I can't take care of this on myself. I need more help. So that struck me as weird. Hey, we've got this psych patient that we're looking at admitting involuntarily. Why don't you go for a walk by yourself for a bit?
Here's a better question. Why is she still in her streets?
Oh.
I would have changed her clothes. Because if you have a high risk for an eloper.
You're meaner than me. You're meaner than me.
Look, this is what, 36 episodes?
This is 38.
38 episodes?
This is episode 38.
I can be mean because you don't want a patient with a high elope risk wearing their own clothes. You'll never find them again. And this is true, Scott, because that's like the biggest issue when we have runners is it's easy to find them when they're wearing our clothes.
True. They stand out pretty well.
Yeah. It's hard to run down the highway.
Very true.
Yeah.
But still, yes, I agree. Like, letting them go walk around by themselves, that is not protocol at all for someone, a psych patient, who you are concerned about harming themselves, harming somebody else, or who is at risk for neglect to themselves even. So yeah, that doesn't happen. I mean, I've definitely had psych patients where, they're really, really overly anxious and they're like, can you please just let me go for a walk? And I will get security and I'll be like, hey, look, I want to avoid having to medicate this patient, but if you would just go walk with them, if you feel comfortable, there's somebody there. I'm down for that. But not letting them go by themselves, like, what kind of crazy person does that?
Crazy person.
So you'd 5150 the doctor. Danger to themselves or others.
Danger to others, obviously, right off the bat. Oof. That was terrible. I just watched the scene it's in my background and just watching her try to walk out the exit and just staring at the exit. Like, nope, not good.
So patient 3 would, I'm going to say that would be the guy who was 2 days till retirement. And basically it was the equivalent of I got 2 days till retirement in a Lethal Weapon movie. I'm going to come in and talk about my fiance, but I can't get her on the phone. You're going to die. You are not going to make it through this episode, sir. I apologize.
God. I knew that guy was going to die the minute they brought him on.
Yeah.
You know why? You know why they killed that guy? Because they always kill the black guy.
There's that too.
So messed up.
But I think, okay, so this was a case for Dr. Halstead. I had to write it down because I was trying to figure it out. A patient comes in with a swollen calf, and he immediately calls it a blood clot without scanning him or checking a pulse or anything. He just sees swollen leg, boom, DVT. And he diagnosed it only with him flexing his foot, like stepping down on a gas pedal. And that's how he diagnosed the DVT immediately.
Could have been murder hornets.
2020 has suffered enough. We don't need to bring in murder hornets on this one. But I've never seen anyone diagnose DVTs, especially a distal DVT, with just plantar flexion.
No.
I mean, you can diagnose compartment syndrome with plantar flexion. You can diagnose.
Well, but that's technically
tear.
That's a clinical diagnosis, right?
Yeah. I mean, this is a patient who probably needed more tests before they just started him on a heparin drip, which they did right away.
Yeah, they did. So kudos.
Yeah.
But yeah, I think it's interesting that one of the patients, they actually tell you like, hey, well, why don't you get a CBC, CMP, UA, chest x-ray, abdominal film. They do that. But on this guy, they're like, oh, nothing. Yeah, you got a DVT. We're going to start you on some heparin.
He's not even on monitors.
You're like, oh, okay. I mean, I get it. Again, like some of this goes into time compression, right? Like they're trying to show that he decompensates very quickly. But come on, man, do this better. Like just, come on. Yeah.
Because they sent him straight to the CT scanner, no IV or anything like that, because he couldn't breathe and his foot was more swollen. And that's the last patient you want to send to the CT scanner without like close monitoring or at least getting some medication. Because like we talked about with Carl, the tummy pain guy, the last thing you want is a decompensating patient in the scanner. And this patient clearly was decompensating. They made him look really sweaty. He had a hard time catching his breath. He wants to talk to his fiance. He can't. He's super tired. And he just looks horrible.
I'll say that overall, Chicago Med has had the most these people actually look like they're dying makeup that we've seen.
Because it's Chicago.
Yeah. It could just be that they live in Chicago. Angry emails to hieverybodypodcast@gmail.com.
Those Polish sausages got to go somewhere, dude.
I mean, at least they stuck to the actual script of how medicine actually works. Like they kill the black guy and tend to ignore him decompensating. Like we just had a case of that in New York, right? Some pregnant woman who I forgot the complete details surrounding it, but she was like, hey, I'm not doing well. Hey, I'm not doing well. She died. And this happens all the time. And I mean, I think sometimes in some of these shows, especially the medical shows, is like, it's a great opportunity to address some of the racial issues that exist within our society, I think, because we're not immune to them, whether implicit or explicit. And these are issues that, you know, you see this guy and it's like, oh yeah, man, don't worry, we got you. We'll talk to your fiance. Yeah, bro, I'm the suave, good-looking ED doc. And you're like, okay, his leg looked horrible.
His leg was horrendous.
And he has, like, I guarantee if you went down like Wells or Perk, like he probably meet like all those criteria. These are all guidelines to assess your risk for pulmonary embolus. That guy probably had like half of them. I don't know. But like, come on. Like you were just going to let him chill and sit there? Yeah, no.
And run his phone down to 4%?
Yeah. I mean, that's the most important thing, man.
Yeah. But then they finally make the decision like, oh, you have a DVT in your lungs. We got to send you to IR. Like that patient should have went from the CT scanner straight to IR.
IR
right away. Interventional radiology. So they actually like guide a wire up and try to send like this medication called TPA to melt the clot so that we can breathe again. Yeah. And it's like all radiology. So they like send a wire up and you can see wires in radiology because they're radio opaque so you can see it. They go up, they like inject the medication and try to melt the blood clot out so he can breathe again. But before they could send him to IR, he codes with the worst sound that one can ever describe in the hospital, which is the sound of a disconnected vent. Because that's the sound. That's not the sound of someone crashing. That's the sound of someone's vent disconnected. It's like boop, 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 boop. You remember that?
It's true.
That's the sound. It's not the sound of someone going into asystole or VFib. It's a sound of someone disconnected your ventilator. And any like resident or nurse that's worked in an ICU or has been around a vent, you hear those sounds, you're like, why? Where is it coming from? Who is not connected to a ventilator right now? Because you'll hear it a lot.
So do I need to change the intro sound effects to this podcast?
To the boop, 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 boop. Yeah, that's the sound. And that was the sound they played when the patient coded. And I could not stop laughing because that was horrible. But he has VFib. And they shocked him.
Yeah. And
That's
I noticed they shocked him with paddles.
Yes.
Yeah, like what is this, the 1980s? Come on, man. That ED is way too nice to be shocking people with panels. That is not how the real world works nowadays. Come on. You got iPads, but you're using paddles? Come on.
Slap some stickers on there and get ready to shock. And they said he was in VFib, and you look on the monitor and it's not VFib. But I will give them credit. Their compressions looked really good.
They really showed those triceps of his.
Yeah. he did it push-up style. Like he locked his elbows and really went for it.
He did.
So he actually,
again, I'll give him the time credit on the time compression there, because you can't.
They called that code. They called that code quick.
Yeah.
They did compressions, gave him one round of epi, and just said
two rounds.
That was two rounds. Yeah, that was the quickest. Again, I think it's because of time compression. I think it's compression.
They called that code super quick. And Scott and I were talking about this before we were recording this episode. Was probably should have given him one more medication before they called the code. When it was the TPA medication, I think is what we were talking about.
And what's that?
So it's essentially the clot buster that Jackson was talking about before. He probably should have. I offline I had messaged Jackson and was like, dude, if you stopped this code, this resuscitation without giving TPA, you would be sued and you might lose that case, because the sole reason presumably that this guy died is because he had a massive pulmonary embolism that was obstructing both his pulmonary arteries, and that's why he died. So I think that's I don't see it. Like, this is one of those realistic things where, like, if you're gonna go all the way and if you're gonna try and be realistic, give the medication, because like literally you will be sued. And like afterward, when they have the conversation, like, hey man, don't worry, buddy, it's gonna be okay in the review. If that was me, I'd be like, I'm screwed. They're gonna be like, why didn't you give TPA? And be like, well, he was dead.
That doctor admin reviewed it so quickly too. It was like 10 minutes after, he goes, you did everything, that's fine. Like, who reviews a case that fresh and that quickly? With the fiance outside waiting to figure out what's going on.
Yeah, waiting for someone to return her call.
Yeah, I thought that was kind of crappy. Like, I understand in the adult world it's a little bit different than the pediatric world, but this guy asked multiple times to, hey man, I can't get a hold of my fiance. Can you call my fiance? Yes, we're all insanely busy in the emergency department. I get it, but I think it's not unreasonable to have attempted at least once, whether you have the nursing, the secretary, or whether that's even nursing themselves. Sometimes they're awesome and they make those phone calls for us because we're running around like madmen. But come on.
Yeah,
I feel like a dick.
I'll take it back to my experience again. My dad was recently hospitalized for COVID and was in the ICU for more than 3 weeks. the nurses, they might not call me back for 3 hours, but they would call me back. They would find the time.
Yeah, and I think that's important.
Right.
I think I think one of the things that we're criticized so much for as doctors is for our absolutely horrendous communication, which sometimes it is our fault. Sometimes it's families who are so stressed out from the situation that it just goes over their head and they don't remember or whatever, but you're right. I think the communication aspect that is displayed in this episode is huge. It's huge because that is one of the biggest failings that I think we have as physicians is we have to communicate well. Yeah. And if we don't, and you can't have this,
I promise I'll try.
Never come in and be like, I don't know what happened. Like, what?
And I make it a point to my residents when I teach them is like, you got to go back to the room and update them what's going on. Because think about when you're on the other side. If you don't know what's going on, you're going to get mad. So always go back, loop back, say, look, this is what's taking a while. This is what we got so far. I'll keep you posted as best as I can. And just making that 30 seconds. It's really not even a minute or 2 minutes. It's sometimes just 30 seconds. Makes a huge difference. Yeah. And I think that's like the big thing with this case is that doctor was very important, trying to fix other people's problems and not dealing with his own problem. Mm-hmm. Which might be a good transition to case number 4.
Yeah, case number 4, which starts out with a doctor with a name.
Dr. Manning.
Dr. Manning, who apparently earlier this season received a traumatic brain injury. And had recently returned to work and was on light duty in the emergency room with a traumatic brain injury.
Those words don't make sense.
Light duty in the emergency room.
Yeah, it's pretty light.
Yeah.
Yeah. Nothing, because, those easy cases never turn out to be something serious, like ever.
Right.
Like, God, this is like an episode of, and I hate to say it, they're trying to make it women be emotional and kind of, which is a horrible way to do it, And like, I hate that they go, hey, this kid just has a bloody nose. And then the doctor tries to pawn it off on a med student going, oh, it's a med student case. Let them deal with it. I've never.
Really?
Yes, that's actually how it started. Oh, it's a bloody nose. It sounds like a med student case. Just give it to a med student.
It was this case is beneath me. Was essentially it's.
And they're making her
you're
seem
pampering me because I have a traumatic brain injury and you don't think I should be treating and you don't think I can treat patients properly. I'm sorry, you don't think I can treat patients properly, but you're still letting me come to work.
And I don't like the way they kind of portray her in this episode. Like, this is a really unfair, horrible way to portray her. But I mean, okay, I will say, maybe it does sound like a med student case, but it doesn't mean as a physician, you just let the med student see the case and then just ignore it. And that's what she's implying is, oh, it's a med student case. A med student can totally deal with this by themselves. There's no way I would let a med student just go see a bloody nose by themselves and just let them discharge them without even doing anything. That's super lazy.
Right.
I don't know if that's a traumatic brain injury talking, but that's dumb.
And then she gets in the room with the patient, and then we find out that the patient's parents, Jared Kushner and and his other wife are holistic medicine anti-vaxxers.
This is I think Jackson and I both deal with this probably more than we would like, and I think this is such a large issue and it's difficult to talk about, but I think this goes back to an extent of what we talked about with like communication is a lot of these people who don't necessarily trust science or trust the
Western medicine, I guess.
We'll just say medicine. We're just going to say medicine because there's no such thing as Western or Eastern medicine. It's just medicine.
Fine.
Like, I think a lot of it stems from a bad experience that they've had.
Yeah.
And I get it. Whether it's ourselves or with family, I'm sure we've all had a bad experience in the medical field.
Yeah.
Or from a customer service standpoint, we've probably all had an awful experience. And so I understand the reticence from the family, but I think Jackson hit the nail on the head. And this was done so over the top, and the portrayal of the doctor just being very almost flippant towards the end. In the beginning, I thought it was actually a relatively reasonable response.
Mm-hmm.
But with these families, to be honest with you, you have to actually really communicate well.
The kid gloves.
Communication is so important because they want to know every single thing about what are the risks, what are the benefits, why are we doing this? And so, which I think is a good thing. I think they're advocating, and that's great.
Yeah.
But she didn't do any of those things.
No.
And I think they purposely did that to set up the conflict
in
this case. And that's whatever. That's fine. That's TV. Cool. Good on you.
These are situations where I tell families, in the beginning, after I learn about their alternative treatment plans, is I go, look, we're all on the same team here. We all want to make sure your kid is better. And I don't want to create new problems. But I also have to go based on what I know is evidence and what works well. And I know there's some things that you don't agree with, but I need to make sure that I do what's best for him without causing new problems, or him or her. And I think that's the big thing that I'll have a discussion with in the beginning. I also will make sure that if I'm looking in a kid's mouth to look for a postnasal drip, to use a light.
Yes. Oh yeah, look, there's a cobblestone back there. It looks like there's inflammation. What?
I'm man, your night vision is great in the darkest ER of all time, and you can look in the mouth and go, postnasal drip. I got it. You got a sinusitis. Also, why are you diagnosing sinusitis on a probably 3-year-old?
Why would you not do that?
Because they don't have sinuses yet.
Correct.
What?
So
yes.
Yeah, they don't. They can't develop sinusitis. So the problem with this, though, is that while Jackson and I are on board with this, the fact is this is actually real. I'll give them props for reality of the situation, because this happens a lot. We're we were at another emergency department, or we went to urgent care and we got diagnosed with sinusitis. My kid's 2. And you're well, the only sinuses you have are your ethmoid sinuses, which are your sinuses in the nose right here. Otherwise, they're not developed. You cannot develop sinusitis. So
your sinuses don't really fully form until maybe 7 is when you get the big ones that you can get sinusitis.
That's insane.
Yeah. So everyone says, oh, my sinuses are congested. They mean their nose. Mm-hmm. The nose is not your sinus. Correct. Sinuses are pockets that are in your skull that sometimes can fill up with mucus. So when you have a really stuffy nose and you're my teeth hurt, what the heck? That's your ethmoid sinuses filling up with mucus, and you're or your maxillary sinuses actually too, filling up with mucus, pushing down on the roots, and that's why you have pain, and that's sinusitis stuff. Or you have a headache in your forehead, that's filled with mucus. That's a frontal sinusitis. That's when you have a true sinusitis, not when your nose is stuffy and you're oh, my sinuses are stuffy.
Yeah,
Johnny.
My mind's blown. I'm done for this episode. Keep going, guys.
I mean, if you want to have debunking garbage medicine talk, Jackson and I are all in for that. But
also, diagnosed with bacterial sinus infection with the labs. Who does that?
Not me.
Yeah,
but the thing is, again, I think I'll give them credit for reality, because that stuff does happen. That stuff happens more times than we would like to think, because in general emergency departments, for people who aren't experts, like those who are trained in pediatric emergency medicine, I think sometimes they tend to overdiagnose something like that. And I think that's the problem with this patient, right? Is you have this person who's oh, yeah, it's probably just sinusitis. They need antibiotics. Well, they don't. And you also just said you think this is all allergies. And then you said, well, why don't we get labs? What are you getting labs for? Even if they have a fever, I'm not getting labs on you. Like,
yeah. But
it
coughing
doesn't
up
change
blood,
your
though,
management.
Yeah, but when they said coughing up blood, I'm like, okay, now we'll dig a little deeper.
Sure.
Yeah.
Sure.
But
that's
like,
fine.
this is like one where they go, oh, he has a sinus infection, let's give him a mox. No, I don't want to do it because he got hives. You can get hives from a mox if you take like it with a viral infection. So, and that's not even technically a true allergy. And then they're like, the reasoning for getting a chest x-ray to rule out pneumonia was, and I quote, because I had to write it down because I was dying, pneumonia is notorious in children for having a slow progression. That heavy sigh was what I had, because she diagnosed him with pneumonia for wheezing, which
technically wheezing actually decreases the likelihood that you have pneumonia, like, significantly.
Yeah. So like, these are all just crazy things.
And that's why I give, to be honest with you, like, I don't know, I'm kind of on the side of the parents in this one. They're like, why do you want to get a chest x-ray? Okay, like, tell them, like, hey, your child's coughing up blood. Yeah, that's probably a good reason to get a chest x-ray. I think that's reasonable. But like, you get the chest x-ray and they're like, well, I don't know. Like, well, I thought you said it was going to be definitive. Well, they're the doctor's right. It is not 100% definitive, but nothing in medicine is. But at the same time, come on, man. Like, if you get a chest x-ray and it doesn't look like there's pneumonia there and the kid's breathing fine and looks fantastic from that standpoint, you know what? I would not be yelling at the parents to be like, oh my God, pneumonia.
Yeah.
So something I don't know if he was if he was the attending or if he was just another doctor in the ER.
Another doctor
said was, this is the second time in a month a parent has doubted your diagnosis or something along those lines.
I would be pissed if someone told me that.
Oh, number one,
super pissed.
Yeah.
Also, why are you counting?
Why are you counting? Number two, I would feel like, frankly, just generally dealing with the general public, if it's the second time in the day someone's doubted your diagnosis, you're probably having a good day.
Yeah. Look, coming from me, I get parents maybe once per shift ask me if I know what I'm doing for sure, or doubting what I'm doing on a daily basis. I just roll with the punches and just be confident in my own skills. But if a colleague calls me out on it, I'd be super mad. That's like not professional. That is not appropriate.
Yeah, like, especially in person like that. I mean, one, that doesn't really happen too often. And man, I hate to wade into these these ideas, but like, there's a part of me where I see that, where I'm like, are you saying this because she's a woman? Like, is that a part of it? Like, why even watch? I mean, like, I know there's that TBI history with this person, with that doctor, but like,
not an excuse.
What are you doing, man? Like, nobody ever has that conversation. Like, I don't keep tallies on other doctors, whether or not I agree with them or I don't agree with them, because we all do things differently. Well,
maybe sometimes.
But like, at the same time, like, one, I'm not going up to him and be like, hey, you're an idiot, so stop. Like, that doesn't happen. Like, that's messed up.
Yeah. We'll never do that. However, her behavior does escalate.
Her behavior escalates slightly when she grabs a IV bag full of antibiotics, locks the door.
This is a poorly designed ED. You can lock doors from inside.
You can lock doors. Also, the lighting on the IVs is the same blue light you see in a dive bar bathroom that keeps you from injecting heroin.
Yeah. They know their audience.
Yeah.
But like, who gives antibiotics to kids without consent, locking the room, forcing the family out? Like, pneumonia for toddlers is not fatal. It isn't. It'll make them sick. It potentially can be fatal, but it doesn't mean it's 100% fatal. Like, this might be a patient.
I mean, You're right. And I mean, I think the other thing that goes along with this is, again, maybe it adds to the reality of it, is that a huge percentage of the time, over 90%, this is going to be a viral pneumonia anyway.
Yeah.
And I think there are a lot of arguments from infectious disease doctors, pulmonologists, data that will show you that, you know what, again, those, what we call like those like difficult parents, they might be right. Like antibiotics may not be warranted. And to be honest with you, unless this kid has some massive pneumonia on the x-ray, they're having difficulty breathing, to be honest with you, I'm not rolling with antibiotics unless radiology in their documentation goes, this is right lobar pneumonia, then fine.
Clinically correlate.
Fine. But otherwise, like in this equivocal case, that's not happening, man. Like I think Jackson brought it up before about these like return precautions and stuff. I would just sit there and be like, sounds good. I'm on board. These are the reasons you need to come back. You know what? Even if you want to be overcautious, you can give them a dose of it. You could admit them, or you could be like, look, I know you don't want to give antibiotics right now and you're going to refuse. That's fine. I'm going to give you a prescription to go home. If your child gets worse, please start them or come back. Pick your poison. I don't care. Like, there's so many different approaches other than I'm going to burn it all down and make sure that I go to jail.
And that's pretty much what is going to happen to this lady, is that she gave antibiotics without family consent, because a family is the one who gives consent for all of this, locks the room, and then just gives antibiotics. And granted, I've been in situations like this before where I'm like, we need to give this kid antibiotics. He will die. And then you have to call the court. The court needs to say it's okay. And you have to prove that this kid is in imminent danger and needs this life-saving treatment. And it's going to be hours, if you're lucky, to get it approved in time. And
it'd be the opposite of the situation with the 5150, where you're probably not going to get a court to pick up the phone immediately to get you out of the hospital, and you're probably not going to get a court to pick up the phone immediately to treat this kid.
Yeah, I think the difference is the 5150, it's safer to presume a 5150 and keep them in, as opposed to letting someone decompensate and die immediately.
Right.
That's the big difference.
And like, I think to the point that you're bringing up is, you know, if you truly thought, you know, if you had all the evidence in the world to show, no, this kid has pneumonia, they're in distress, they need antibiotics for whatever reason, because of the pneumonia, and you're like, look, they need antibiotics. You know, I think Jackson brought up like, well, fine. You don't want to do it. We're going to admit them. If parents keep refusing. So technically we have the right to override families in the case of an emergency if we think that is the right decision. Again, this goes back to that psych discussion that we had. We try not to do that because we would like families to be on board for these decisions, right?
Yeah.
But if a family really doesn't want to, for whatever reason, you can admit them and you can be like, all right, fine, we'll hold off. But I guarantee you, when a family sees that their kid is starting to decompensate, that they look like death, they're not going to sit back, or at least no reasonable family is going to sit back and allow that to happen to their child or to anybody in their family.
I mean, in my personal experience, I had a patient where the mom was like, nope, no antibiotics. He's going to be fine. I want to use my natural stuff. I'm like, you can. I'm just going to admit you to the hospital so they can watch you overnight, because I'd rather you get some sleep knowing someone's paying attention to him, making sure he doesn't get sicker while you're using your medications. However, if we need to give him the stronger medications, I know you don't want to do this now, but if he needs the stronger medications, he's in a place where he can get it immediately instead of you coming back. And usually selling it like that and doing a joint decision-making where you go, look, you need to stay so we can watch you, works a little bit better instead of being cavalier, locking the door and giving medications.
And losing your medical license.
Correct.
Because you're never going to practice medicine again after that.
Oh, yeah. That is someone who's not. And that's how that episode ended, was
right.
crazy doctor locking himself in.
Uh,
Spoiler.
And then next episode, doesn't she end up releasing a video called Plandemic?
Don't.
Can you stop? Don't promote that. Don't promote that.
Don't you promote that evil Johnny.
Oh, man.
Don't you dare.
They just opened the beaches, Johnny. Come on.
I don't want them to close it. But the spoiler was, it wasn't pneumonia. It was an autoimmune disease called Wegener's. Or they called it something else. They used the acronym. But that's an older person disease where they get it.
Yeah.
That's like a 40 to 50-year-old person.
I hate when they do this stuff. When they're like, well, they had, Wegener's. And you're like, okay, is it possible for the kid to have it? Sure. I mean, this is like house stuff.
Yeah, I was going to say, it's house syndrome.
Like, come on. Like, yes, we can do the 1 in a million or 1 in a billion case. That's fine. It's just not how the real world works. I guess it's more interesting because it allows the story to get dragged on. But I mean, I think the issues around the cases are actually the interesting parts of it. And I think the human dynamic that occurs is more interesting. But I don't know. Maybe that's just me. I don't know.
Yeah, this was terrible.
Yeah.
I did not like this case. It brought back very, very many bad memories with dealing with patients like this. And it's tough. You're wearing kid gloves the whole time because you don't want to say anything to offend them. And it's so rough. This is basically an example of how not to handle any of this.
Yeah, it's pretty bad. It's pretty bad. I mean, I would like to go back to what I thought at the very beginning, which I thought was, I love that they always do this in the medical shows. The ED doctor who like goes and flirts with the nurse or whatever. And like, I think he even like gives her a kiss in the emergency department.
Dating.
Yeah, they move in together next episode.
Cool.
But it still works.
But like, you know what like doesn't happen in the workplace anywhere? That. And like, it's not appropriate, man. Like,
I think the term you're trying to come up with is don't poop where you eat.
I mean, I get, look, that happens all the time. It happens all the time. But how overt it is ridiculous.
Yeah, not appropriate.
I mean, I'm sure Jackson, you have some stories from
friends,
training or medical school or from friends that stuff
some colleagues.
Happened.
Yeah,
I certainly do as well. But like some of this stuff, I'm like, dude, it's not as salacious as you think. Like, to be honest with you, us as doctors, we're kind of like nerdy people who have spent like, God knows, 30 years of our lives getting to where we got to. And, you know, it's not like that every doctor out there, one, is insanely good looking, like the doctors in every single TV show out there. And two, is just like a chick magnet. It's not like you're just like, hey, what's up, nurse? Yeah, I know you want it. I'm a doctor. Like, that's not how it works. Like, even if I was single, I'm married. Like, I can't go up to a nurse and like put my hand on her shoulder and be like Joe Biden her. Like, I don't know, you know, like this doesn't work. Like, this is creepy. You know, it's not real. It's not real.
It is not. It is definitely not.
Gosh, man.
You know, should we transition? That's a good transition point to number 5.
Yeah,
the last one.
It actually kind of ties into the don't poop with your eat. Don't poop with your eat. Why have I stopped being able to speak English on this podcast the last 3 weeks? Don't poop where you eat. I think significantly less podcast use as we record has been the problem. You've got the doctor in the she's a nurse in the hospital who's diagnosed with breast cancer and is hiding it from her colleagues and also getting treated at that hospital.
Yeah.
Question. How do you hide it from your colleagues and also get treated at that hospital?
That's the weirdest hair loss pattern I've seen. It was just like male pattern baldness.
Yeah, she has my hairline.
It's all good, man.
But her eyebrows
it looks good.
Yeah. You can't really. Like, I think seeing your colleague being really tired and pale. Also, if you're getting active chemo, the worst place you want to be is an emergency.
Oh, yeah.
Yeah.
Like
No,
you're
it's
surrounded
true.
by germs. It's terrible.
I mean, there's so many things wrong with that whole thing. Like, one, she's like out of breath at one point, and
Yeah.
they're like, "Oh, hey, you doing all right? Yeah, yeah, I gotta go."
I'm
Like,
stressed out. Yeah.
Yeah.
you look like you're gonna die. Again, maybe Chicago Med crushing it on the reality of people look like they're gonna die in the
Yeah.
episodes, but like, she looked horrible,
Yeah.
horrible.
Agreed.
And also, I don't know how many times on a shift, whether that's a nurse, a doctor, anybody else that you work with, goes, "Hey, I gotta go," and they can just like walk out.
It's impossible. You have an
Who does
assignment.
that?
You have an assignment of rooms to take care of, at least in California. You have your assignment. You have a certain number of patients to take care of. You're in charge of those rooms.
I'm
You
just
can't
going to
just
work from
go,
home
I'm
for the
leaving.
rest of the day if that's okay.
Yeah. I'm just gonna leave. Not my problem. Someone else. They can push the meds. I know. I would love to do like telehealth emergency. It's impossible. It's like the hardest thing to do. But
unless
like,
you've got that many iPads in the hospital.
So many iPads.
With
so
a robotic
iPads.
arm that I can put a breathing tube in. It's the way to go, man. But like, so they show a scene of her going to the infusion center and getting her quote unquote chemo. And it was just gentamicin and saline. And I know, Johnny, you were asking, what's gentamicin? It's an antibiotic.
I was going to say it's got a mycin in it, so I know that much.
Yeah.
So you brought this up, and I was like, that's just weird. So I did actually look this up and see if there was anything on PubMed, and supposedly there is some evidence that gentamicin is something that could be used for breast cancer, but I am not aware of it being used on its own. So it's
I haven't either.
A little weird, but
yeah. And usually if you are going to use chemo, a lot of the times the chemo is really photosensitive. So they put it in like a dark bag to hide it too. This is all from experience. This is what I've learned. Where you actually had to put it in like a dark bag to cover it up and then they infuse it in. But also if you're going to give it through a port, which is what she had on her chest, you try not to have the shirt and all the cables all touch the shirt and all that stuff. And I think that's why your friend brought it up, Johnny, to do this episode was that is not how you use a port.
No.
That is a very...
They'd be keeping it as sterile as possible.
Yeah, you probably would want to have it exposed as much and not touching everything. That port is basically going straight towards your heart. And you don't want to introduce bacteria towards your heart.
So you don't want to work in an emergency room and have an open port.
I mean, in theory, her port shouldn't be
open.
Okay, so it's not something that they leave it. It's not like a permanent. Like she keeps the same port there all the time.
So a port, think of it like how do I describe it? It looks like a gumdrop that's big underneath your skin that you can put a needle into it, and then the gumdrop actually has like a little catheter that goes towards your heart.
Okay.
And you can insert a very long needle into it to access the port. But the thing is, you want to make sure you're super clean. So anytime someone is dealing with the port, they're like dressed up in gowns, wearing surgical gloves, masks, and all that. They don't want to spit on it or get droplets on it and then accidentally introduce bacteria on the surface of the skin into the chest.
So they don't sit down next to you and have an apple and a conversation while you're getting your chemo.
No. Maybe in those like DaVita kidney dialysis
places.
Maybe in those DaVita places they do. I don't know.
They were going to sponsor us next week. Dang it.
Oh, we can't use DaVita anymore.
That would be a bad sponsor.
Crossing it off. DaVita, get it out.
DaVita's out. Gilead's out.
Are your kidneys not working? Call DaVita.
No thanks. No thanks.
And then them de-accessing the port. They just kind of unhooked up that one wire and just left it open. Like, you're done. You need to flush it with heparin and all that stuff, and then really sterilely remove it and all that stuff too. So that part is kind of bad.
Okay,
too.
so it's not a it stays in all the time port. It's a
no. The port is underneath
there.
It's in your body the whole time, but you don't have usually shouldn't be having anything hanging out of it for a prolonged period of time.
Got it. Okay.
Unless you want an infection.
Yeah. Which
Okay.
I did have a lot of psych patients that would try to access their port and then shove poop in it.
Was this in New Mexico?
No, it was in Long Beach.
Oh, okay, that's fair.
And then can I just mention one of the most ridiculous and probably favorite part of this episode was when she revealed to her coworker she had cancer.
By just they all walked out at the same time and took off the wig.
And then she took off her wig. Yep. She wig revealed just to show that she was bald. And everyone immediately said cancer. Not male pattern baldness.
Yeah, or psoriasis.
No. Everyone knew right away.
Alopecia.
Nope, cancer.
You're being harsh. You're being harsh on that one. I'm gonna give it a pass. I'm gonna give it a pass. I think it's a weird way to reveal that you have cancer, but fine.
Hey, wig reveals are big now. If you watch RuPaul's Drag Race, everyone has wig reveals, and that's a big way to reveal. Oh, my wife watches a lot of it.
I think we can, at least Jackson and I can both agree that the proper way to reveal is to sit down and say, the tests came back. It's definitely breast cancer.
See, that's the way to reveal that you got breast cancer.
Right, and then talk about Johnny's promotion at the bank.
Correct. That is the way to go. Scott, I hope you know what we're talking about.
Wow, I really hope that's not a real life occurrence that occurred. Because nope. Johnny, I'm sorry.
No, that's the Room. Which is
cinematic.
Greatest, yeah.
Oh, it's so good.
It's a cinematic masterpiece.
Oh God,
it's so good.
All right. Good. Speaking of cinematic masterpieces,
I
have an important question, and this is Scott's first exposure to this question. The human centipede bills itself as 100% medically accurate. Oh. If that's the case, how medically accurate is season 5, episode 5? Of Chicago Med, A Friend in Me, Dr. Scott Herskovitz.
Letting him do it first.
Wow, thanks, buddy. Appreciate just throwing it out there for me, huh? All right. I'll give. I think there was some medical accuracy to this episode. I think some of it, I'm like, holy crap. You lost your license, you're going to jail, and you're probably going to get sued. So, there's a couple things on there that I'm like, that's crazy. But some of the other stuff, I actually didn't think it was too horrible. I'll give it, man, maybe I'm being really nice right now. Maybe there's things that are way worse than this. I'm gonna give it a 50%.
Oof.
Okay.
Harsh.
So 100%. Human centipede is our baseline. Human centipede is 100%.
Okay.
So you think it's half as medically accurate as the movie where people where faces get sewn to butts and you're being nice.
I mean, that's a very accurate movie. Especially the second one. Come on, guys.
Oh, you mean full sequence? No. I'm not going to be as harsh as Scott. I will say it's 80%. I think look,
Chicago exists.
Chicago exists. It is a real place. Ooh, yeah. I will say the stress of dealing with a toddler, parents who don't believe in traditional medicine, very aggressive, very upsetting. However, would not do what she does. Actually, no, I'm gonna go down 70. Now, because I'm looking through my notes, I'm like, man, there's a lot of bad stuff in here. I mean, worse than sewing butts to faces, like bad. Like it's not good. It is not a good episode. I mean, it is definitely worse than last week's episode where we talked about The Resident. Surprisingly,
yeah,
that was a surprisingly decent episode.
Jackson, one of the people in this show is gonna go to jail for what she did. The other person...
Hold on. That's medically accurate.
All right. Fair enough. Maybe I need to raise my bar. I'll go maybe 65%.
I'm just saying, if you push meds and stuff like that, you're going to jail. And that is 100% medically accurate. I would say the chemo stuff, bad. The crazy Asian lawyer lady, pretty close, except for all that other stuff. The DBT stuff could have been done better. That one was just bad medicine, not inaccuracy. The bad medicine part came from someone just going in and going, you did everything right. Which I feel like you might say that in a bad code situation. You're like, look, you tried everything, you did everything right. But when it goes to like M&M or case review or anything like that, they'll be like, oh man, there's a lot of stuff that went wrong.
M&M is morbidity and mortality
mortality.
when Marshall Mathers comes and reviews how you did.
Correct. Slim Shady comes and reviews everything. I think I've only been in one case where everyone outside of the room goes, that went horribly. And it wasn't my case, but it was one case where everyone's, oh, that was terrible. Why weren't you there? I'm like, don't drag me into this. We'll talk this offline. Yeah. But that, I think the percentage I gave, 70%, is
all right,
where I stand. 65 is good. No. You argue your number. That is a big part of why the episode. Because you argue why you're doing what you're doing.
There's definitely more reality to it. I think you're right. It's just
not good.
Yeah.
It is worse than the Human Centipede.
It was a lot of mistakes compiled into 42 minutes of television.
5 cases is too many cases for an hour of TV. That is way too many. Because
that's true.
The DBT case are just like, oh hey, guess you're dead. That's essentially the storyline. It's like, oh, all I know about him is he has a fiance, he can't breathe. Oops, he's dead. Oh, the fiance never talked to him. The end.
Oh, and he played tennis yesterday.
Oh, and he played tennis yesterday. This is one storyline that could have been stretched for the whole episode as like the B plot easily, and it would have had the same stakes.
Well, maybe the next episode of Chicago Med is about implicit bias in medicine, and there's a massive riot in Southside Chicago because the idiot doctors did not take the black man's symptoms
seriously.
Right, seriously. Maybe that happened, and I'd be
okay
with that.
If
they did that, I would be okay with that.
Scott, what also that implies? That I'm going to be able to get through another episode of Chicago Med in the next week. Some of these episodes really take a lot out of me, and this is one of them.
We've talked about it a little bit over the course of the episode, but is there something that you would change other than doors that lock on the inside to make it more medically accurate while keeping the dramatic stakes high? Because the dramatic stakes were constantly at least an 11 throughout this episode.
They were.
I mean, they didn't slow down.
Quite high. No.
Have you seen the movie Before Sunset? They managed to make nothing have high dramatic emotional stakes. Like, come on, man. You could make this. There's so many reasonable stories that you can give in medicine that aren't outlandish, that do show how medicine actually works, that displays the human side of medicine, and as well as kind of like incorporating some of the social issues that we deal with on an everyday basis that we're not immune to. Yet instead we choose to make medical shows that display like garbage, random, rare things that occur, or hot button issues, instead of like in this episode, like you said, five stories. Pick one. Like I'll give House props that they basically, for the most part, will like pick like one patient and go through it. It may be ridiculous, but at least they pick one patient that they just examine the ridiculousness of the patient.
Yeah. Mm-hmm. I'm going to agree with a lot of that. I would also say this episode has too much with so little done. My brain
I don't know, man. You're right. I think it's just so hard. Like, I don't know if we've had this discussion, like what your favorite medical show is. Like, I don't watch any of this garbage, but for me, like, right? Like, I think you talk to like most doctors and they're like, hey, what's the most accurate? And you're like, Scrubs, man. Like, you have a show about a bunch of learning amateur doctors who have no idea what they're doing, and that's what training is.
Yeah.
That's what training is, and that show was great.
Everyone was too cocky in this show, I think. I think that's the biggest thing, is everyone was very prideful. Yeah, every single doctor. And I think I texted you about this, Johnny, before the episode. I was like, I don't think anyone's likable.
Yeah.
I don't think anyone was likable.
That's we texted back and forth after watching it of, do we want to do this one, because we didn't like the characters. Any of them.
They all suck.
Any of them.
They all suck so much. Except for maybe Oliver Platt.
I was going to say, yeah.
They all sucked. They all suck so much. But yeah, this was a tough episode, but there's clearly a lot that can be fixed.
I expect better things from Fast and the Furious Tokyo Drift guy. I expect better things.
I expect better things from Dick Wplf, because, I mean, Law and Order was 100% legally accurate.
Oh, man. I will say this, Scott. Like, the Hobbs and Shaw movie was a good one.
It was good. I found it entertaining.
That is probably one of my favorite movies I saw last year.
I had low expectations for Hobbs and Shaw, because I haven't seen many of the Fast and the Furious movies. I haven't seen, like, maybe since the first or second one. It was great. It was a blast.
It was just entertaining. It was just pure fun. It was pure fun. You know what, this show, Chicago Med, not pure
fun.
This show lacked fun. This show lacked the lighthearted whimsy of The Resident.
Don't you put this on us.
The Resident is whimsical. Have you guys done an episode of New Amsterdam yet?
Oh God, no. That's next. that's on the docket, by the way.
I think for the sake of Jackson's brain and liver, our next episode will probably not be a medical drama.
We have to do a brain dramas in between. Otherwise, no, we did do back-to-back.
Yeah, we did do back-to-back.
Yeah. Okay.
All right. Well, thank you, Scott, for joining us. Thank you, Jackson, once again. Thank you, everybody, for listening. This was a much more in-depth episode than I anticipated when I watched the episode of Chicago Med the first time. But
good luck editing this one.
But thanks, folks, for listening. We'll be back next Tuesday with more of this. So thanks, folks.